Thank you. A challenging title, but I will start. I started CPR as cardiac research 21 years ago. At that time, I remember very well my first meeting. There was no talks about post-arrestation care because there were almost no survivors. I mean, the world has really changed the last 20 years, and this is a study where we looked at outcome in Oslo over a 10-year period. You can see we can compare 3 periods. In the end of the 90s, we had bad CPR, bad ALS, and really bad post-arrest care. In 2001 and 2003, based on several studies from our group, we had improved quality of CPR with good CPR, good ALS, but still bad post-arrest care. In 2003, we changed our guidelines to a standardized treatment protocol that I will show you later. And you can see, especially in the last period, how the survival really more than doubled for all causes, for cardiac cause and for cardiac cause post-ventricular fibrillation during that time period. And the most important effect was due to better post-arrest care. So to treat these patients well, you need to understand the post-cardiac arrest syndrome, which consists of several factors. These are the most important ones. The underlying cause of the arrest. The majority of these patients have coronary heart disease, acute myocardial infarction that has to be detected and treated. Then they have an ischemia and reperfusion syndrome. The primary ischemia before anyone starts CPR, which we know, of course, is detrimental if no one starts CPR within the first 4 or 5 minutes to the brain. Then the secondary ischemic damage starts immediately when we start CPR. That's the reperfusion injury due to the global ischemic damage, all those products that damages the circulation, and it's also affecting the brain circulation. Then we also know that these patients have a systemic inflammatory response syndrome, a sepsis-like syndrome. Exactly the same mediators we see in sepsis are also released in cardiac arrest patients, and they have a severe myocardial dysfunction that requires good treatment for us. We need to give them fluids, vasopressors, inotropic agents depending on the situation. I'll come back to that. So this is a severe reperfusion syndrome with hemodynamic instability, and that has to be kept in mind when we treat these patients. And the quality of care matters. This is from Sweden, and you can see each bar represents a hospital. Here, among the admitted patients, 15% were discharged, and in this hospital, 45% were discharged alive. So, of course, quality of care matters. If you have a good treatment protocol or if you have a bad treatment protocol, that impacts on outcome. So, of course, if you have no plan, you will lose the majority of your ROSC patients. So we had all this in mind when we, in 2002, created this standardized treatment protocol that changed practice in Oslo. And you can see here, before we had the treatment protocol, our survival was around 31%, 26% with favorable outcome. That was average in Europe around that time. And after 2 years, with implementing a standardized treatment protocol, you can see a doubling in survival, and that all survivors were also alive after 1 year. And this number, over 50%, has stayed the same the last 15 years in our unit. And this consists of a 24/7 coronary angiography PCI treatment, hypothermia to 33 degrees. We still do 33 degrees, I'll come back to that. Hemodynamic optimization, management plan with fluids, vasopressors, inotropics, even intra-aortic balloon convincing patients. We have a blood sugar control, standardized sedation protocol, seizure management, but importantly focused multidisciplinary teamwork, and we care about these patients. So that has all contributed to this improvement in outcome. I have to emphasize that the hemodynamic management plan is important. We have to assess their heart function. We have to assess their cause of shock. Why do they have a low blood pressure? It might depend on the cause of the arrest, but it might also depend on different situations. Some have cardiogenic shock, some have vasodilatory shock, some have other causes of shock, and that requires different treatment. It's not that we need to give norepinephrine to all patients, it's depending on the cause. And also, this is also challenging because the brain and the heart have different needs. If we want to push up the pressure in a patient because we think that the brain needs more blood, a higher blood pressure, that might strain the heart a lot, and the total situation doesn't look good. So we need to think at both the brain and the heart when we treat these patients. And there are knowledge gaps here too. Probably there are different targets based on temperature. The physiology at 33 degrees is not at all the same. Sorry for those changed marks. But the physiology at 33 is not the same at 36. and it's not a one-size-fits-all treatment plan here. So these are all the challenges we have. So with this in mind, for me it's very important to present this, because hypothermia is a part of the bundle. It's not hypothermia versus nothing. It's hypothermia as part of a bundle. So when we do this well, we need to again understand the reperfusion injury, and there are a lot of studies the last 20-30 years at least on animals, showing how all these factors impact on the reperfusion injury, and that temperature impact on these processes. I have no time to go in detail. The temperature impact on these processes, I think we all agree on that. And these factors are all associated with the reperfusion injury in the brain after cardiac arrest. So, and there has been a lot of animal studies, as I told you. The majority of the studies are in rat scare bells. There are some studies in dogs and pigs, but I agree with Hans, the majority of the studies are on smaller animals. And of course, we cannot extrapolate everything from small animals to big animals, but these are big animals or human, but these are at least the data. And the data, if we summarize everything, is that 32 to 34 is better than normothermia. Hyperthermia is detrimental. It's also been shown in patients. Time to hypothermia initiation is important. I will come back to that. There seems to be a therapeutic window. Intra-rest cooling is best. That will be covered in the next talk by Fabio. And to deep cooling have more severe side effects and it is not beneficial. So this, again, doesn't quite fit with the TTM trial. Why? I think we have to look into a little more detail. This is a study, a Gerbil study, and actually they assessed the brain 6 months after cardiac arrest in this study. And they looked at different time to hypothermia. Groups were cooled after 1 hour or after 4 hours. And you can see, and then looked at the effect on cells in the hippocampus, CA1 region of the hippocampus, which is the most vulnerable region after ischemia. And you can see here, if you started cooling after 1 hour, 34 degrees or 32 degrees, you had quite many intact cells in this region. But if you delayed cooling with 4 hours, you had no effect on hypothermia in these small animals. 4 hours. So if you look at the animal studies, there is a clear arrest point, there is a clear arrest point, and they induce hypothermia fast. So these groups differ very early, very different from the clinical trials that we are doing. This is the TTM trial. For example, in the TTM trial, when was the cardiac arrest? That is not here on the list, because inclusion criteria was 4 hours from ROSC to 240, also 4 hours from ROSC to inclusion. And you can see here, this is time point 0 is inclusion. And you can see again here, in the early hours, there was no difference in the group. That means the first 5, 6, 7 hours, the groups were very similar. And if you ask some scientists working on hypothermia treatment, Bob Newmer or Lance Becker, they say, if I would have treated my rats this way, I would have no effect of hypothermia. So it's different. So I kind of ask this question, it's just a question, with a neutral result from the pragmatic TTM trial, are we concluding based on the current way we TTM treat our cardiac arrest patients that perhaps isn't optimal? Or are we concluding based on the true effects of hypothermia on the reperfusion injury? I think you know my answer to that question. And there are some difficulties here, because confounding aspects regarding early cooling. We know from several studies, has been also published in several studies later, also a sub-study from the TTM trial, that the lower core temperature at hospital admission and more rapid cooling response, that means no resistance in the brain, is associated with higher mortality. So if the lack of protection against the drop in core temperature is due to a larger and deeper brain injury. So if you are really dead, you are colder, and it's very easy to cool you fast. And that, of course, makes problems for all these studies where we try to show that fast cooling improves outcome, because we include all of these patients that are totally dead. And, of course, they make difficulties in the scientific interpretation of our data. So how do we optimal cool these patients today? I mean, there are two major groups, external surface cooling or internal cooling. And the combination of different methods is probably of benefit, as some can be used in different settings. But for me, it's also important to consider pathophysiology when we cool these patients. Because, for example, there have been studies where they used cold fluids during CPR, the RINSE trial in Australia. I already told Bernard when he created that study that I don't understand why I do this study. Because if you give a lot of fluids during CPR, you will increase the right atrial pressure. And if you increase the right atrial pressure, you will reduce the coronary perfusion pressure. And that's important during cardiac arrest. And the situation is totally different after rust, because then we are not dependent on the coronary perfusion pressure. Then we need fluids in these patients because they have sepsis-like syndrome and a myocardial dysfunction. So again, when we create studies, we have to look at the pathophysiology. This is the results of the RINS trial, where they give a lot of fluids during CPR. And of course, there was a lower rust rate in those patients that got a lot of fluids. So although you cannot conclude that hypothermia is the reason for no effect, because pathophysiology were used perhaps, I think, wrong in this study. So there are different cooling methods, and I think there are no data that we can say that one method is better than the other, and each institution should use the method that they prefer. But it's actually one quite interesting study from France, published in Circulation some years ago, where they compared traditional external cooling with an endovascular cooling device. And if you look at the data after 90 days, there was actually no significant difference in outcome, but there was a clear trend towards better outcome in the better cooling group, where they had better cooling. The log rank test, you can see here a p-value of 0.052. So was this really a negative trial? No difference? Was it underpowered? And what about outcome after 1 to 2 years? It was after 90 days. We know that cool patients changes over time regarding their cognitive function. So I'm not sure if this is a negative trial. So a few slides about the most common side effects: infectious pneumonia, electrolyte disorders, shivering, hypoglycemia, hemodynamic effects, seizures. We have to be aware of these effects and treat them correctly. But importantly, and this is perhaps one of the major reasons why we still do 33 degrees, because there were no major side effects in the 33 versus the 36 group. So since we have good results the last 15 years, and it's a neutral trial with no difference in harm, we keep on with what we have done the last 15-20 years. So some practical aspects. Shivering during hypothermia, okay, we need to avoid it. But when I see that in my patient, it's a good sign. It's associated with better outcome, because that shows me that I have an intact brain that reacts to hypothermia. But we need a sedation protocol to try to avoid it, of course, but when we see it, it's normally a good sign. Then the blood sugar disturbance is important to be aware of. So we need to have an insulin infusion, and we need to measure blood sugar frequently, because it changes when the temperature also changes. Target normal oxygenation, normal ventilation, avoid hyperventilation. It's a very interesting study, the TAME trial, that will look at different targets for CO2. That will be important. And it's important when you cool patients down, because the metabolism is reduced, that you adjust the tidal volumes, reduce them. And again, measure frequent arterial blood gases so that you don't end up hyperventilating your patients. Bradycardia is also a natural sign that appears because the brain because the brain reacts to hypothermia. And we actually did a study where we saw that hypothermia, that bradycardia, here you can see successful survivors. They had a lower heart rate during the 24 hours during cooling compared to patients with, that had a bad outcome. They had a higher heart rate. And you can see after 8 hours and after 20 hours, the lower the heart rate, actually the better the outcome, and the higher the heart rate, the worse the outcome was the same. So again, if the blood pressure is okay, lactate production is okay, keep the heart rate down, because it's okay. And actually, if you increase the heart rate, you will worsen the diastolic dysfunction because you increase the heart rate. So leave the heart rate down if blood pressures are okay. So this is a typical patient. You can see here low temperature, PICO catheter used in our patient. You can see the low heart rate here, and the cardiac index is very low. But that doesn't matter, because the patient is cooled, and central venous oxygenation is fine, and the brain doesn't need more oxygen during hypothermia. So, as you understand, hypothermia is part of a standardized goal-directed bundled post-rotation care with the main goals of vital organ perfusion. If you treat it to 33 or if you treat it to 36, you have to optimize those other therapies, and you have to optimize the standard intensive care treatment. And again, as Hans also emphasized, 36 degrees is also temperature management. And this is an interesting study from Australia, from Bernard's group, where they actually showed what happened before and after they changed from 33 to 36 degrees. You can see here, this is the period where they had 33 degrees. Almost all patients were at the target. But when they changed to 36 degrees, they didn't care so much anymore, and only 50% of the patients were at the target to 36%. They used less sedation at that time, and you can see here that they were extubated a little earlier if they cool them to 36, so you get them faster out of the ICU. But this is a little scary. The CPC score went down. It's not significant. It's a small study, not many patients, but it's a clear trend towards worse outcome among those patients that were treated not optimal with a temperature above 37 degrees. You can see also here the numbers of CPC1 is different compared to CPC2. And for the patient and the relative, I mean, we judge all of them as good outcome. It's a big difference to be a bad CPC2 or a good CPC1. So in summary, they emphasized that, that in fact, to keep these patients at 36 degrees requires also the same work that they do to 33 degrees and may in fact be more difficult. So to conclude, this is the natural temperature curves if we don't have temperature management in our patients. You can see, and this is true for Norway, for Australia, for all countries. Due to the cerebral ischemic injury, yes, it's the last slide. Temperature falls, but due to the injury, the temperature increases during the first 24 hours. And at that time, when we didn't have any temperature management, we had a survival of approximately 25%. That means patients with minor reperfusion injuries doesn't need temperature management at all. We will have survivors if we don't give hypothermia. This is the control group in the HACA trial, 39% good outcome, where the temperature was around 37.8 in average. And this is the intervention group, 33 degrees, with a 55% survival. This is the TTM, 36. You can see here clearly this is temperature management. And same survival with 33 degrees. And these are the data that we have in Oslo, a survival for approximately 54%. So, conclusion, TTM, avoid fever, 32 to 36, probably not a one-size-fits-all. 36 is still TTM, and long-term outcome, quality of life, is of course the most important thing for these patients. Thank you.